Morning, everyone. Today I'm going to present a seminar on treatment-resistant depression and moderate Sanjeev Gupta. So we'll be going through the introduction, definition, and staging of treatment-resistant depression, causes of poor treatment response, study trial, result and implications of study trial, management, and novel approaches and brain stimulation techniques. So first of all, introduction. What is complete remission? It is achieving full response of psychosocial functioning with minimal residual effect and is the therapeutic goal for major depressive disorders. Despite the efficacy of various treatments, about 1 in 3 patients remain clinically depressed after multiple treatment rounds and 10 to 20% patients remain symptomatic for 2 years or longer. Starry trial revealed that 63.2% did not remit following first trial and up to one-third patients never achieved remission. So definitions and staging of TRD. So there is a lack of consensus. There is no universally accepted definition for resistance or refractoriness in the clinical practice. None of the TRD definitions are universally accepted, and none of them are supported by external validator or biomarkers. So the first is US FDA. According to US FDA, TRD is failure to respond to two or more antidepressant regimens despite adequate dose and duration and adherence to treatment. Then there is stage and rush staging model. This defined TRD along a continuum of failed treatment trials. Failed antidepressant trials. So number of treatment failures required it to be called as TRD is 1 and adequate trial is defined as 4. So in this staging, there is stage 1, which is failure of at least one adequate trial of one major class of antidepressants. Stage 2 is failure of like 2 antidepressant trials. Stage 3 is stage 2 plus failure of one TCA. Stage 4 is stage 3 plus failure of one MAO inhibitors. And stage 5 is stage 4 plus failure of bilateral EC. The limitation of this model was that they have not defined any or what is non-response, no consideration for any psychotherapeutic intervention, and no consideration of depressive features such as duration and severity of the index episode. Then is Maudsley staging for TRD. It was developed to improve upon the Theisen-Rush model. So it defines treatment resistance as failure to attain significant level of improvement, that is clinical remission, from an accurately diagnosed depressive episode following treatment with an antidepressant given at an adequate dose of for a minimum of 6 weeks, and a number of treatment failure required is 1. So this staging model, they have considered 3 parameters for treatment failure, for treatment resistance, that is duration, that is symptom and severity of the current episode, and the treatment past treatment failures. So according to that, they have given 3 stages of TRD, that is mild, a score of 3 to 6, moderate, a score of 7 to 10, and severe, a score of 11 to 15. And the limitation for this was that they have also not considered any psychotherapeutic interventions. Then there is European Group of Study of Resistant Depression, GSRD. They, for the first time, defined treatment response as a reduction of less than 50% in the total score on HAM-D or MADRS scales. The TRD as of they have defined TRD as a failure to respond to 2 or more adequate trials of different class of antidepressant with 5 different level of resistance. And adequate trial, they have defined it as 6 to 8 weeks. And also a definition of chronic resistant depression, which is failure to respond to several antidepressant trial and augmentation strategies of an overall duration of at least 12 months. Then there is Dutch measures of quantification of treatment-resistant depression. This is the most comprehensive model because they have included all the like functional impairment, comorbid anxiety symptoms, personality disorders, psychosocial stresses, several categories of augmentations. However, they have also like kept the number of treatment failures to call it as depression 1. They have not given any definition of non-response, and physical comorbidities and childhood adversities are not considered. Then there is MGHS model. They describe this treatment failure, like they have given this points for every treatment failure, every drug failure, they have given 1 point. And for every like optimization of dose, optimization of duration, augmentation, they have given 0.5 score. And for electroconvulsive therapy, if it is used, they have given 3 scores. Again, on this basis, they have classified the treatment-resistant depression, and EDUCATE trial is of 6 weeks. Now, treatment resistance consists of three core components, that is a correct diagnosis, educate treatment, and non-response. So if there is a non-response to treatment, first we have to check if the diagnosis is correct or not. If the diagnosis is not correct, then it is a pseudo-resistance. If it is correct, then we have to see if the treatment is adequate or not. If it is not, then it is pseudo-resistance. And if the treatment is also correct, then that is treatment resistance. Now, the causes of non-response can be syndrome heterogeneity. That is, like there are some undetected conditions or bipolar disorders, primary degenerative dementias, or Parkinson's disease, which may initially present with the symptoms of major depressive disorders. Now, inadequate dose or duration of antidepressant trait variability, persistent psychosocial stressors, untreated medical comorbidities like diabetes and hypertension, and counter-therapeutic behavior. So what are counter-therapeutic behavior? That is poor compliance to treatment, which may be due to the waning of symptoms, the stigma associated with it, the weak therapeutic alliance, and the low tolerance of somatic side effects, substance abuse, and erosion of adaptive coping behavior. That is, remission may provoke fear of once again facing responsibilities and stresses, and the patient can cling intentionally to the sick role at the expense of full functional recovery. Now, sequence treatment alternatives to relieve depression, that is a STAR-D trial. It was the largest prospective clinical trial of treatment of major depressive disorder. They enrolled 4041 patients of non-psychotic major depressive disorder with substantial chronic and recurrent depression and comorbid psychiatric and general medical conditions. The aim was to determine which of the several treatment is the most effective next step for the patient who do not reach remission with the initial subsequent treatment and who cannot tolerate the treatment. So they have evaluated the effectiveness of 11 pharmacologically distinct drug-drug interactions, and they considered remission as the primary outcome. So this trial was conducted at 4 levels: level 1, 2, 3, and 4. At level 1, the patients were given citalopram, and after 12 weeks, those who did not if the patient responded, then they were taken for the follow-up for the next 1 year. If they did not respond, then at level 2, the patients were given a choice if they want to switch the drug, that is to stop the earlier drug and to start either bupropion sustained release, venlafaxine extended release, sertraline, or cognitive therapies, or to augment, that is to keep the previous drug and to add on that bupropion sustained release, buspirone, and cognitive therapy. Then if the patients not responding to this, they were then taken for level 3. Level 3, again, the patient was given choice between switch and augmentation. In switch, now the drugs that were considered were mirtazapine or nortriptyline. And for augmentations, it was a lithium and T3 thyroid hormone was. And at level 4, those not responding at level 3 were taken to level 4. At level 4, there was only one option, that is switch to either tranylcypromine or to mirtazapine plus venlafaxine extended release combination. So the results was with that after step 1, only 33% patients showed remission, and after step 2, it was 50%, step 3, 60%, and step 4, 70%. Like one third of the patient, even after step 4, did not show remission. So so according to this, the participant requiring more than 2 well delivered treatment may be characterized as treatment resistant, given that substantially lower remission rates after that point. The non-remission was associated with various medical conditions, psychiatric condition, chronic index episode, recurrent course, more anxious, atypical, and melancholic symptoms, more prior treatment failure, and greater initial depressive symptom severity. If the first treatment doesn't work, either switching or augmentation was the reasonable choice, but augmentation can be preferred in the patient tolerating receiving partial benefit from the initial medication. The study did not say anything about that if you can switch from within class or different class antidepressants. So no significant difference in the remission on switching among within class, out of class, or dual action agents. And then acute phase response and remission rate become even lower with more failed treatment. Relapse become more with more failed treatment trials. And the psychotherapy should be offered before the third medication step is taken, given its high tolerability and apparent effectiveness. And expect poor antidepressant outcomes in patients who abuse alcohol and others. Now, the management of TRD. So the patient who do not respond within 4 to 6 weeks of the treatment of the first line antidepressants, they can be like following treatment options can be considered. It is either optimization, switching, combination, or a adjunctive therapy. What is optimization? To optimize the dose and duration of the antidepressant. So 60% of the person of the patient who achieved remission in study trial with level 1 treatment did so after 6 weeks of the treatment, indicating that a subpopulation of adult with MDD may require longer treatment trial. So extending the initial trial beyond 4 to 6 weeks is indicated if there is an increment but slow improvement during the first 4 weeks of treatment. Second is switching. So the results of study suggest that changing to a second step treatment results in additional remission rate of about 25%, and further changes are associated with continued remission but at a lower rate. So a better response rate of up to 70% is reported when patients are switched to an alternative class of antidepressant with different mechanism of action. So the advantages of switching is the lower cost, a single side effect profile, a simpler dosing regimen, and an improved adherence. And the disadvantages are therapeutic gains from the original antidepressants, they are lost. The patient has to wait for the newer agents to become effective, and the relapse of withdrawal. Now, there are two methods of switching, that is a V method and the X method. The V method, that is complete tapering of the initial drug before starting the second drug, and the X method, that is gradual tapering of the initial drug while the second drug is introduced, resulting in crossover process. Then there is combination of antidepressant. So combination is addition of a second antidepressant agent from the same or different class to the therapeutic regime. So in level 2 of study trial, the augmentation was done with bupropion. So bupropion combined with citalopram, remission was 39% compared with 25% when switching to bupropion sustained release monotherapy. Recent meta-analysis concluded that alpha-2 autoreceptor antagonists like mirtazapine, nyansarine, and trazodone combined with SSRI are superior to monotherapy in mixed populations, including treatment-resistant depression. Now, the advantages of this is the rapid response, and disadvantage of switching strategies are avoided. And the disadvantages are this is associated with reduced compliance, increased likelihood of adverse effect, prone to polypharmacy, and increased drug interactions. Then there is adjunctive or augmentation strategies. This adjunctive means addition of a second medication, which is a non-antidepressant, to the first line pharmacotherapeutic options. So the main strategies are either adding lithium, T3, second generation antipsychotics, and anticonvulsants. So lithium, the APA and the World Federation of Biological Society, NICE guidelines strongly recommend lithium as an effective augmentation strategy for MDD. However, it is not FDA approved. The study trial reported a 16% remission in the group of patients taking citalopram augmented by lithium. Then triiodothyroxine, a study trial, no statistically significant superiority over augmentation with lithium was discovered. But the group receiving T3 reported significantly fewer adverse events than the group receiving lithium. Now, thyroid hormone supplementation, even in the euthyroid patient, you can increase the effectiveness of antidepressant. So those usually starts with 25 mcg per day, and that can be increased to 50 mcg per day. And the duration of the treatment required is not well studied. Then second generation antipsychotics, aripiprazole at a dose of 2.5 to 5 milligrams per day, quetiapine at a dose of 150 to 300 milligrams per day, and brexpiprazole are all studied on the patients with a partial response to at least one antidepressant. However, only SGA, which is FDA approved for the patient failing 2 or more prior antidepressant trial, that is treatment-resistant depression, is olanzapine fluoxetine combination. Risperidone has also shown effects, but it is not FDA approved. Now, the studies have compared the antipsychotic augmentation of antidepressants versus combination of antidepressants. The VAST-D trial found that response rate was significantly higher for aripiprazole group than for bupropion SR monotherapy or bupropion SR augmentation. Lamotrigine, it is used at a dose of 100 to 400 milligram per day. It is a well-researched strategy. However, disadvantages include slow titration regimen and risk for lamotrigine-induced rash as well as Stevens-Johnson syndrome. Now, the psychotherapeutic intervention. So, standalone use of any psychotherapy, the research is limited, the data is limited. However, the evidence support efficacy of adjunctive psychological intervention in person with TR. Then novel approaches in the treatment resistant depression. First is ketamine. So in 2019, FDA approved intranasal ketamine spray combined with antidepressant in adult with TRD. There was a trial, ESCAPE TRD trial, which compared the efficacy of quetiapine and intranasal esketamine, and they found indicated that intranasal esketamine combined with antidepressant is significantly more effective than quetiapine X are in treatment-resistant depression, and there is less evidence of other available forms of ketamine for this purpose. Now, how does ketamine work? It acts via NMDA receptors and by increasing the dendritic spine formation. The dose should be given in conjunction with oral antidepressant. So for the induction phase, that is for the first 4 weeks, administered twice per day. Day one starting dose should be 56 milligrams, followed by subsequent doses of 56 to 84 milligrams. And for maintenance phase, that is for 5 to 8 weeks, administered once weekly at 56 milligrams or 84 milligrams. And week 9 and after, administered twice weekly or once weekly at 56 to 84 milligrams. And starting dose for the patient greater than 65 years is 20. Then is S-adenosine methionine. So it is the end product of one carbon cycle, and it is suggested that MDD is associated with dysregulation of one carbon cycle. So S-adenosine methionine affect the regulation of various monoaminergic neurotransmitter systems like indirect and direct modulations, and they can be given at a dose of 400 to 1000 milligrams. Magnesium has also significant role in promoting synaptogenesis, which is in prefrontal cortex. So it can also be used. Now, this is a table from Morsley, which shows the first choices in treatment-resistant depression, which include addition of aripiprazole, addition of lithium, addition of combination of olanzapine fluoxetine fixed dose combination, then quetiapine, SSRI plus bupropion, or SSRI plus or venlafaxine plus niacinamide or metazapine. The second choices are addition of ketamine, addition of lamotrigine, ECT, and addition of triiodothyronine. Now, the brain stimulation techniques, the vagal nerve stimulation. The vagal nerve stimulation entails the direct intermittent electrical stimulation of the left cervical vagus nerve via pulse generator implanted on the left chest wall. So the electrodes are placed around the left vagus nerve in the neck and is connected to the generator subcutaneously. It sends significant signals to the nucleus tractus solitarius and connected limbic and cortical areas, and thus it alters the serotonergic activity in the cortical and the limbic structures. So it is efficacious in high order TRD, that is in equal to or greater than 4 prior antidepressant trials. So it is FDA approved in TRD patients with history of at least 4 prior failed antidepressants. RTMS, it reports the reported remission rates are 25.1% across 23 studies. High frequency RTMS over left DLPFC is FDA approved in 2008. And ITBS protocol with MRI guided functional connectivity targeting, that is Stanford neuromodulation therapy, were recently FDA cleared for TR. ECT is well-established therapeutic intervention in the treatment with an average open label remission of around 48% in non-psychotic depression, and efficacy is higher in individual with psychotic depression. TDCS, so first by Pregnian collaborators in 2006 to describe the antidepressant effect of anodal TDCS over the right prefrontal dorsolateral cortex. So the anodal stimulation lead to depolarization of the neuron membrane and thus evoke an increase of the spontaneous neuronal firing rate in the DLP. So the data is insufficient currently for the TDs. These are my references. They were comparing combination of antidepressant with ketamine, nasal ketamine, and antidepressant plus a second generation antipsychotic. Yes.
Add-on protracting versus add-on.
Add-on executor.
लगा रखा है मुझे ये फिर भी। हाँ, बिल्कुल, ये भी हो।